Hello and welcome to Beyond COVID, a panel discussion organized by the Caribbean Vulnerable Communities Coalition, CVC, to explore the impact of the COVID-19 pandemic on members of key population groups across the Caribbean. My name is Sabrina Daly, and I'll be your host for the next hour as we take a closer look at the issues. There's no doubt that the COVID-19 pandemic has upended all of our lives. The past 2 years battling the pandemic have been very difficult for all of us, with everyone having their own unique challenges. That is why today we want to zoom in on how the pandemic has affected the lives of key population groups in Belize, such as persons living with HIV. Later in the show, we'll be hearing from a couple groups who work with these individuals. But before we take a deep dive into these issues, let's start by getting an update on the COVID-19 pandemic in Belize. Where are we with getting more people vaccinated? And are people just tired of hearing about COVID-19? Is pandemic fatigue setting in, or has it? To answer these questions and many more, we have the Ministry of Health and Wellness representative with us, Dr. Melissa Diaz-Musa. Welcome.
Thank you.
Dr. Musa, you were a key component on the ground, as well as for policy level, in battling, in fighting COVID-19 in Belize. Talk to us from a medical perspective about your initial reaction to the pandemic.
Okay, sure. This COVID-19 pandemic has caused a challenge for many health systems all over the world, and Belize is no different. You know, a lot about it when we started to hear about COVID-19 and started to look at the absolute newness of this virus. We knew nothing about it except looking on the television, seeing what was happening in other countries and how quickly COVID-19 had spread, the way that it transmits, and the severity of disease that it was causing to many people around the world. And we knew that we had to get our response as quickly as possible. We had to get ready. We had to get our teams on the ground as quickly as possible. And like you said, you know, put in protocols in place and get policy in place. Of course, Belize has been significantly impacted by COVID-19. We can say direct and indirect impacts, and short-term and long-term and medium-term impacts. And we're still going through a lot of it. We recorded our first case in March of 2020, and we recorded that as our first wave. And that first wave was pretty small. It was less than 20 persons, after which we went into a full lockdown of the country, including our borders, the airports, and that continued until about May, when we started to repatriate our people back into the country. At that time, I must say at this point that there was such a great learning curve for us, a steep learning curve for us as healthcare workers. And our healthcare workers in the country were very much able to step up to the plate, if I must say. Yes. We were able to train quickly. We had to ensure that they were flexible in what they were doing. We had to cross-train. Even non-technical staff, environmental vector staff had to learn how to swab, to use the testing. We had to train the laboratory staff as well to ensure that they can do PCR testing. So everybody really stepped up despite the fears and despite the uncertainties of COVID-19. And for this, you know, the Ministry of Health and Wellness, we continue to be grateful to our staff for what was done. And I know personally from many experiences calling out staff in the middle of the night, early in the morning, to go to visit homes, to go to the borders, and people were very willing. And I think that that formed a big part of our ability to address and contain the different waves as quickly as possible. Of course, there were definitely certain game changers in our response. And in the latter part of 2020, rolling out our rapid testing was really important, because this allowed us to very quickly identify positive cases, isolate them quickly, and do our contact tracing and quarantine the contacts very quickly. So all of that formed a part of our ability to contain a spread as quickly as possible. And then, of course, coming into 2021, we started our vaccination program in March of 2021. And we had a phased approach to the vaccines, mainly because there were so many uncertainties of how many vaccines we would get, what kind of vaccines, which countries will be priorities. And, you know, that happened with a lot of negotiating, health diplomacy between different countries, working with COVAX through WHO, PAHO. So there was a lot that we had to do on the ground to get ready to ensure that we were able to get vaccines. And our priority groups were the healthcare workers were the first priority, along with persons 60 and over and persons with comorbidities. And again, we believe that that has made a significant impact on our mortality and morbidity data when it comes to COVID-19. Because when we go further on in the year and we saw that we had our second wave in September to December of 2020 of the original virus, we had what our case fatality rate, which is of the amount of persons who died over the amount of persons who got the infection. That rate was almost 3% in that first wave. The second wave, which was Delta, which we all know is one of the more severe variants of the disease, even though we had more persons infected, our case fatality rate was 1.9%, which tells us that, you know, the proof of the pie is in the eating. We do know that the vaccines given during that time had helped our vulnerable population, because even the elderly, obese, diabetics, hypertensives were, even though some were hospitalized, they were surviving a little bit better than when the year before with no vaccines completely.
I think this is also a good opportunity to look into the steps taken when a person was infected in 2020 versus now. Could you share some light on that?
Yes. Well, I mean, the first wave, when we look back at it now, like I mentioned, it's something that we would say, you know, we could have, in Belize City, we could have still been out and about. But we didn't know how transmissible it was, if it was, you know, there was still data being looked at, research of, you know, if you have a non-living object, is the virus going to be staying on that? And we were tracking the path of where these people came from, and quarantining everybody in the airplane. And so it was much different. But even as we learned about it, and when we saw what was happening with Delta as well, we knew that, you know, we had to work fast and we had to continue to isolate and continue to quarantine persons who were defined as close contacts to that positive case. Everybody reacted slightly differently, and it wasn't something that we could sit back and say, oh, you are young, so you will survive, because we had young persons dying. We had pregnant women being severely affected as well. So it was something that we had to keep our guard up to protect the country, to protect persons, and of course, very importantly, communicating with the public and ensuring that they understood why certain things were being done. And, you know, we expect that you can't always please everybody. Persons might think that, you know, some things might be an overreaction. But at the end of the day, we were looking at our numbers, we were looking at our hospitalization, and we were the ones taking the calls and you know, advising. So we knew that certain public health measures had to keep going until recently, and looking at Omicron, seeing that when Omicron came on board, it was less severe, and even more so now with BA2 and BA5 and BA4, we know that the severity isn't as much. But having said that, we still have persons hospitalized with COVID. So it depends on your body's immune system, how you react, and the severity of the disease that you got.
I would imagine that those persons are persons with severe underlying conditions as well.
Yes.
And going back to the question in terms of the measures being taken for persons that are infected with the virus, I know when we first had our first case, or at least in the first phase or the first wave of the virus, there were requirements that persons should be isolated for, say, a week.
No, well, this has changed significantly.
Yes.
So when we first got in the first wave with the 18 or 20 persons that were diagnosed with COVID, those persons, and according to WHO, they were recommending that these persons stay in isolation until 2 consecutive negative PCR tests were received. So unfortunately, we had persons in isolation. Some persons were up to 50 days or 40 days because they kept getting a positive, not realizing that the PCR was also picking up dead viral cells. Now that we have the the use of the rapid tests. We could correlate the rapid test and PCR in certain circumstances. And we were able to as well put in very strict testing protocols that all of the Ministry of Health private and private facilities also followed. So we do know that if you had symptoms or if you were deemed a close contact and your rapid test was negative, we would go on to do a PCR to confirm that you were a true negative. So all of this had, has changed completely our isolation time. Once we realized that you are no longer infectious after about 14 days, that infectivity period goes down, we then restructured our isolation protocols so that it would match that, after 14 days you get retested and then you go back to work. And now as the virus has changed significantly, we know that the infectivity period is within 7 days, on average. It's not saying that a person cannot be sick or cannot infect you after 7 days, but on average, that's what we look at. So now our protocol has changed to 7 days. You can leave your isolation, provided that you're well. If you're unwell, of course, we don't want you to go to your workplace coughing or being sick.
So. Dr. Musa, I remember the reaction from the public to this virus. If you cough, if you sneeze,
everybody's like,
everyone's side eyes. Everyone gives you a side eye.
Definitely.
But there was also a reaction to the vaccination as well, the vaccination campaign, or just the idea that this is the unknown and we don't necessarily know how this virus is developing, so we're not necessarily open to being vaccinated.
Yes.
There were views that if you catch the virus, then that's kind of like a vaccination as well.
Some immunity, yes.
That gives you immunity. Talk to us about what the public's reaction was to the vaccination.
Yes, I think that initially we were pressured by the general public to get vaccines into Belize as quickly as possible. And as a ministry, and we have always promoted vaccines in our country. I mean, in Belize we have, for example, childhood vaccines, over 95% in all areas of childhood vaccines. So we are a country and a population that we do believe in vaccines. And when your baby is 24 hours old, they've already received 2 vaccines. So it's something that we have not had many problems with that at all, especially in school-age kids. And then when you go to university or as you get older, other vaccines come on board as well. With the COVID-19 vaccines, the issue was the newness about it, or the unknown, like you quite rightly said.
Yes.
Persons were skeptical because the vaccine was made so quickly, and there was a lot of communication that had to be strengthened, especially from the vaccine agencies, from WHO, from CDC, and people had to look at these things, and people were skeptic to say, well, it might be a lie, these things are not true. But we knew in the Ministry of Health how important it was for us to get vaccines into our country as soon as possible. And initially when the vaccines came in, there was definitely a very good uptake. In fact, for healthcare workers, we had almost 99% of healthcare workers vaccinated. And for persons 60 and over, they really came out. And that was a high percentage as well. Over 70-something% or more of persons 60 and over. Who came in and got the vaccines. And of course, we were also there to support our team. We were there with, if persons felt ill, we were trying to provide water, and the community came out to support with juice, with other things at all these vaccine sites. Because you've seen some of the footage of what was happening all over the country.
Yes.
I think that a major problem, or not, the area that was most concerning for a lot of people was the newness, the uncertainty, and the quickness to which the vaccine was developed. And then finding out that even if you got vaccinated, you can still contract the disease.
Yes.
So we had to ensure that we promoted that message, that it doesn't stop you from catching the virus, but it helps you from getting severe disease, from getting hospitalized, and from dying from the virus. And I think once we made that clear, and once we saw that more and more persons were getting vaccinated, and other people saw that, okay, nothing has happened, they're doing well, they have very little side effects of the vaccines, we were able to get more people vaccinated. To date, we have almost 54% of the total population vaccinated, but before getting the Pfizer vaccine, we were up to 70% of the targeted population, before getting the 5 to 11 Pfizer. So in terms of the uptake, I think that the uptake was good. It could have obviously been much better, and especially for the 5 to the 11-year-old, because we knew historically over the last 24 months that children were not being affected as severely as elderly persons or persons with comorbidity. So parents were also very skeptical and wondering, oh, should I give my 5-year-old or my 6-year-old, when we know that they recover generally quite well unless there's a significant underlying problem with the child. So that was some area as well that we had problems to get vaccinated. And younger persons as well. I think younger persons were generally waiting. They brought in their parents and grandparents, but they were waiting to see, you know, maybe the virus won't be as bad. And like you said, people felt that if you got the virus, you would get immunity, which you do. You do get immunity, but the problem is that, for instance, like influenza virus, there are thousands of strains. So you might get an influenza strain today, and in 3 months' time you get it again because your body does not recognize that second strain, or your immunity wanes as the time goes on.
All right. Well, we definitely will continue this conversation on vaccination in our after the break. So we will be taking our first break and returning with Dr. Melissa Diaz-Musa to dive deeper into the conversation of vaccination, as well as where we are currently, this current phase of the pandemic. Is COVID fatigue setting in, or is it already here? So we will discuss that and more when we come back.
It is very unusual to get COVID after you take the vaccine. But of course, if you've only taken your first dose and you're within 2 to 4 weeks, then your body has not responded fully to the vaccine dose yet. And if you're exposed to COVID, you could get it. Once you get both doses of the vaccine, then you are certainly protected against severe COVID. Very few persons may get infected or mild symptoms, but most people will not get severe COVID, will not need to go to hospital, and they will not die from COVID.
I am going to die. I remember saying to myself when I first tested positive, although I knew persons living with HIV were not dying like before, people's prejudices were still the same. I wanted to keep this a secret, but it proved impossible. My father threw me out saying, "Batty boy, and now HIV positive too?" It was very difficult to deal with being rejected by people and accept my new reality. When I began my treatment, my whole life changed. I pledged to live life to the full. I only had to take a single pill a day. I felt great. I made new friends and got a job at which I excelled. I didn't care what others said. That was until COVID showed up and a collective paranoia set in. Some neighbors started to say that I was infected. I knew I had to battle the most lethal of viruses, that of fear, ignorance, and discrimination. At least, this time I knew what to expect and could brace myself.
We've all been impacted by COVID-19, but there's more than one side to the story. These are the stories that go untold.
Based on numerous clinical trials data, the vaccine candidates that are now under emergency use authorization in different parts of the world have been shown to be very safe as well as effective. Some of the most common side effects that we've seen coming out of clinical trials include fatigue or restlessness, pain at the injection site, and some persons may mount a mild fever, which is consistent with your body mounting an appropriate response to these vaccines. So overall, the vaccines have a very, very good safety profile. And on top of that, there are health systems and bodies that look out for adverse effects.
Welcome back to Beyond COVID, a panel discussion organized by the Caribbean Vulnerable Communities Coalition, CVC. I'm still here with Dr. Melissa Diaz-Musa, a representative of the Ministry of Health and Wellness. We continue our conversation on vaccination, and we touched on the uptake, the statistics so far on the vaccination rollout in Belize, the campaigns that you guys have pushed out to encourage persons to become vaccinated against the COVID-19 virus. But I also want to talk about the reluctance that we had. We kind of touched on it briefly, but some of the reluctance from other communities or other collectives as well. Before we get into particular groups, I'd like to touch on, again, what were the reasons why persons would not want to be vaccinated. We even had a news story where there was a collective that came together against the vaccine as well. And I think it's important to touch on that to really expel what those ideas were of why one should not be vaccinated. So could you?
Yes. Like I had mentioned before, I think that a main part of the skepticism lies in the fact that the vaccines were made very quickly, within a few months. In addition to that, there were rumors as well, a lot of rumors that came up regarding vaccines and regarding how they were made. You know, some church groups as well were concerned about whether fetal parts were used or fetal cells. And so it was important for us as the Ministry of Health and Wellness to ensure that we provide information, accurate information to our community. There is an aspect of health that's called risk communication. And risk communication looks at targeting areas where we know persons are concerned about, or targeting things or myths that people have with regards to the vaccine. So, you know, it was important for us to look at our strategies as best as possible.
Yes. Talk to me about some of the myths, Dr. Musa,
yes.
that you
as I had mentioned earlier, you know, people were saying that a vaccine cannot be made so quickly, although we know that with technology, with the improvement in science and with vaccines as well, we do know that that's possible. And so many ads that came out from WHO, from CDC, and from other organizations, we were able to pick back on and utilize as well to show the general public that there are mRNA vaccines, there are certain types of vaccines. These ingredients are not used, you know, and we actually, one of the biggest strategies is that we started to do a lot of education in smaller groups. So instead of sitting at our health facilities and waiting for persons to come in, we started to go out. We started to go into community centers, into fields, into villages, so that we made the access to vaccines much easier. We were able to get a lot of staff, human resources. We were able to pull in nurses who had retired. We got doctors on the ground as well to give vaccines. We trained, we ensured we had the cold storage and the freezers that could hold, you know, the ultra cold vaccines as well. And we showed that constantly on the TV. And like you said, you know, we were on the television regularly, and we tried to address, even in small groups, concerns. We gave out flyers, we did ads, jingles, raffles. So we did as much as possible in order to target groups. We found, you know, in Belize, in the country, we have the majority of our persons living in urban populations, but we still have a large amount of people in the rural populations. And many persons were saying, okay, they want the vaccine, but they cannot get to certain facilities. So we ended up going into putting mobile schedules in the buses and in the bus stations and going into different villages on a regular basis as well. And then we saw that, you know, we did have an improvement in the uptake, as well as when businesses started to open. Many business owners in private sector especially were very much for the vaccines and tried to help to ensure that we could go into these businesses, speak to the staff, and many business owners were asking that their staff is vaccinated in order to protect the entire environment as well and the vulnerable people at the workplace. So many of those strategies helped us to get to the number that we got to quickly. Of course, as symptoms and COVID fatigue, like you mentioned, it is real. And as symptoms started to become less severe and persons started to get back into some kind of normalcy, we see that our uptake has definitely fallen significantly. We've recently received some more Pfizer vaccines in the last week as well. And we've recently started to re-strategize to ensure that we visit schools and we go out to the students, the parents consent from before, and actually put COVID-19 vaccines in the school vaccination program as well. And that has helped us to increase that sector, that uptake. When we got the pediatric vaccines, it was just before school closed in summer. And for that reason, we're able to do a few visits. But now we're really focusing on going back to the schools and promoting. But what has worked for us is when we go into communities, educate them first, answer questions, and we show that, you know, you can trust us with what we're saying. We have to work with evidence-based medicine. We've got to look at, you know, the medical advice from bigger companies and research organizations as well. And we provide that to the persons with questions. And we see that when we go back with the vaccines, all questions have been answered, and the persons who were reluctant prior went ahead and got the vaccines. But of course, our numbers need to improve.
Yes. Would you say that the numbers have become a bit more stagnant after the booster shots came in?
The numbers became more stagnant with Omicron. And I think that, you know, the general public look at the situation and determine that, oh, I've caught COVID, I have some immunity, it wasn't as bad as I thought. So everybody has an individual perspective or opinion with regards to what COVID is like now. And that fear factor is no longer the way it was with Delta and with the original variant. And, you know, all of that affects the uptake of vaccines. But having said that, we know that we vaccinate for diseases that are much rarer now: diphtheria, tetanus, pertussis, BCG for tuberculosis, hepatitis B, and people uptake these vaccines. So it will become a part of the COVID-19 routine. Vaccines will become a part of the routine vaccination schedule. So it will always be available for persons to uptake.
So I mean, what I was looking at though was the idea that people have that you already take your first and your second vaccination, but then you're also required to do a booster shot after. Mm-hmm. So that's why I was asking, do you think that the reluctance comes around the booster shot because it's like, okay, yes, how much of this are we going to take? Yes. Or is it just the reaction to the virus, I guess, seeming weaker after
yes,
a while?
Yes. Well, we do know that with this particular vaccine and even with natural immunity, your immunity may wane over a few months. Now, we don't know how many months it would take. Some people might have their body's defense stronger and keep that immunity for quite a longer period of time. And we didn't know what kind of variant would come up next. You know, every time you turn on the TV or every time you got information, there was a new variant or this was happening in another country. And that's why we promoted the booster. And the booster uptake was very good. Okay. At this point, I believe that we've stayed very stagnant between 50 and 53. It has taken us about 2 or 3 months to get to 53%. Okay. So there was a steep curve. There was a steep curve before, and then we started to really plateau, and now we're slowly going up. But we have continued, like I said, to re-strategize, trying to reach persons who are never vaccinated, as well as trying to do other things like we have jingles on, we have raffles, other things, and the school visits, and going into the community.
Do you think that where your numbers lie right now, the fact that it's a bit more stagnant, do you think that it indicates that we are feeling COVID fatigue?
Absolutely. COVID fatigue is real for healthcare workers, for the general public. And a friend of mine, we always talk, and she says, you know, a pandemic is over by 2 things, whether it's naturally over or whether the population decides that we've had enough. Yeah. And we do know that COVID fatigue is real, and we know that there have been, as I said, direct, indirect impacts and long-term impacts of isolation, of all the changes that we went through as a population. There's so many different things: mental illness, the awareness, or many people coming so close to dealing with death of loved ones. So a lot of this has also caused persons to say, you know what, I want to get back into a normal way of life and the way things were before. And we've learned a lot as well from the pandemic, and we know that even with technology, all these things have helped us throughout. The things that we thought we weren't able to do, we were able to do during COVID.
Yes.
So,
what do you anticipate our new normal to be, the way forward after COVID?
I think that COVID, we know in health that behavioral change takes a long time, and that's why we have this risk communication, because you can't just say to somebody, take this vaccine, and they will quickly take it. You know, you've got to address the concerns and find out, you know, how can you make this behavioral change in order to improve health. And I think that as in human nature, we go back to what we're comfortable with. I know schools have gone back to regular classes, but we always keep in mind, and like you said, you know, if somebody coughs, sneeze, oh, you still mentioned it could be COVID. So we always keep in mind the hand sanitizing. And for the younger generation, I see, you know, the children always looking for the sanitizer when they enter buildings and things that they have now been brought up with. And so there will be change, but I believe that human nature is that you go back into what you're comfortable with and what you're used to.
Yes. Well, Dr. Diaz-Musa, thank you so much for joining us here on Beyond COVID. You parted with us some very, very important information, and it really speaks to where we were, where we are, and where we could be if we continue on the path of fighting this virus. Yes. Thank you so much for joining us, and we hope to not see you on the next pandemic.
Yes, thank you so much for the interview as well. And I just wanted to end by saying that as a ministry, COVID-19 has taught us to prepare quickly, and we are now even better prepared for whatever might come our way when it comes to infectious diseases.
Yes, yes.
Thank
you very much.
Okay.
When we come back to Beyond COVID, we'll be joined by the civil society organizations and how the COVID-19 pandemic has impacted persons living with HIV. We'll have that and more when we come back.
I believe that as a young person, COVID-19 would not affect me. The gravity of my brother's situation with the virus showed me just how untrue this was. We put on face masks but continued to go to the parties and to the beach. We truly believed that COVID only affected the elderly. We felt invincible. We both ended up catching the virus. I was asymptomatic, but my brother developed serious complications. My grandmother, who is a diabetic and also lives with us, got it soon after we did. She and my brother are now hospitalized with oxygen tanks. I'm really scared. I don't want anything to happen to either of them. I would like to be able to turn the clock back, to behave more responsibly, to have more respect for this virus that may have spared me, but has had such a devastating effect on my loved ones.
We've all been impacted by COVID-19, but there's more than one side to the story. These are the stories that go untold.
When it comes to pregnant women and the vaccine, we have to weigh the benefit and the possible adverse effect very closely. Pregnant women were not systematically included in the vaccine trials, so we don't have enough data about the vaccine in pregnant women. But we do know that pregnant women who get COVID are more at risk of a serious illness. So if a woman is pregnant and she's a frontline essential worker, like a doctor or a nurse, then she may choose to get the vaccine because she is at high risk of developing COVID. So you weigh the individual benefit from protecting yourself against the virus, against the risk, which we don't think there's any risk from taking the vaccine if you're pregnant, but we don't have a lot of data. What we are now doing is any woman who got the vaccine, became pregnant, they are being followed up to make sure that there is no adverse effect either on the mother, the woman, or on the unborn baby. But we are confident that over time, the vaccine will prove to be safe for persons who are pregnant.
Welcome back to Beyond COVID, a panel discussion organized by the Caribbean Vulnerable Communities Coalition to explore how the COVID-19 pandemic has impacted the lives of members of key population groups, such as people living with HIV. In the segment, we'll hear directly from representatives of the civil society organizations right here in Belize. With us, we have Daricia Castillo Salazar. She is the managing director of Our Circle. Hello.
Hi.
We also have Kieran Cacho. He is the monitoring and evaluation officer of Go Belize. Hello and welcome.
Hi.
Thank you so much for joining us.
Thank you for having us.
So we are on the conversation of COVID-19 and how it has impacted the masses. But a key conversation is also the vulnerable communities. We could start on either one of you talking about what it is that you guys do or what your organizations represent, and then we can touch specifically on COVID and how it has impacted that.
Well, Our Circle, the organization that I represent, works with lesbian, gays, bisexual, and transgender families. These are persons who self-identify as lesbian, gay, bisexual, transgender, and either intend to or have already established their own families. Okay. We look at legal and social discrepancies which exist for us to be able to minimize those discrepancies and level of discrimination so that we can actually have all of our families, whether they're LGBT families, whether they're straight families, single home families, having access to the same rights and social services.
Yes. And yourself, Kieran?
So Go Belize actually focuses on youth, the youth populace within the country of Belize by building the capacities, enrolling individuals into strengthening their abilities to lead, to learn more about sexually productive health. And more recently, Go Belize has focused on building capacities of other organizations through the civil society organizational hub, which drives this work in building and advocating for these marginalized communities, MSMs, persons living with HIV, trans communities, and youths, just to name a few. We've done this work through the collaboration and collaborative effort of the hub with various entities that strive for rights-based approach when it comes to the provision of services in general to these key communities.
Yes. So it essentially looks like there are times where the work that you guys do overlap. In touching, though, on COVID, talk to us about how COVID-19 particularly, or how would you say COVID-19 affected these subgroups of vulnerable people?
Well, on the onset of COVID in 2020, Our Circle, with the support from the CSO Hub, launched a small research that was done to pretty much look at the first quarter of COVID existing or becoming a reality in Belize, and the impact it had on LGBT persons. We widened it from just the families to looking at persons, because eventually what we saw, we saw three key thematic areas where the LGBT persons were actually being impacted. Two of which was universal, their access to health care, their access to income and a way of survival. But two very key thematic areas which jumped out was the mental health aspect of it, and the fact that these persons who were already faced with several mental health issues, it elevated at that point, at this onset of COVID, with this insecurity of what this virus meant, what it was going to do to us as people, what it was going to do to us as a country. And on a larger scale, what we saw was, because the country was shutting down, a lot of our community members lost their jobs, who majority of them were actually in the tourism area, were forced to go back home. And for someone who is not a part of the LGBT community and not associated with what home may actually mean, you may think, well, that's comforting, go back home, mom, dad, sister is there. But when mom, dad, and sister don't accept you and your identity, or you and your partner, or you and the family that you've created, that's where an additional stress kicks in. So what we saw was that a lot of these people, in identifying their independence, had their own jobs, had their own space, created their own families and life.
Yes.
But here came COVID, taking away their independence and having to, especially San Pedro, being one of the first places to close down. A lot of them had to evacuate from San Pedro and come back to the mainland to a mom, a dad, an aunt, someone who did not understand, yes, or even accept or even tolerate their way of living, their identity. And that again coupled into some of the mental health issues that we saw. We knew even before COVID, our community had anxiety issues, faced depression. Some of them looked to substance abuse as their comfort. And going back into these households where they basically fled from, to create that level of safety for themselves. COVID forced them back into that.
Remove them from their source.
From their, yes. And what we saw was a lot of the families which were formed had to separate. So there were a lot of couples who could not move back into the mainland, or could not move back to where would be their quarantine space with their partners. So we would see where a lot of people, and especially where it's a communicable issue at this point. You can't say, okay, can I sleep on your sofa until things pass by? Can I come over and get some food? So it created this level of isolation.
Because any form of interaction could
make yourself, your household, make everybody vulnerable to COVID. So we saw where that isolation really, really impacted the LGBT community. And that was an additional burden, if I can use that word, which may not have been associated with our heteronormal counterparts, because it stemmed out of them having that independence pre-COVID and now going back into a situation that a lot of them fled from. And that really, like I said, maximized the level of mental strain that was put on a lot of the LGBT persons here in Belize. So for us, I think while we acknowledge that the financial strain, the lack of resources when it came to healthcare was something that was indiscriminate, having that safe space being taken away from you, your formed family being taken away from you because you had to move back. You had to go back to somewhere that you know you weren't being, you weren't being not even tolerated, because acceptance is a lot. Some of them went back to places where they weren't tolerated for their sexuality or their sexual orientation or even their gender identity. That was a big one for us to navigate during COVID, during the onset of COVID.
I definitely want to continue this discussion with discrimination and not being accepted within that vulnerable community. But just to continue with the question on your part, Kieran, could you talk about how COVID-19 affected your organization?
It was very challenging. Like most persons in early 2020, we had to pack up and go home and try to reevaluate how we were able to meet our communities and at the same time our organizational goals. And at the same time, strategizing how we are able to evolve as COVID evolved, or new norm as it was termed. For us, persons living with HIV has been one of the communities that we have advocated and strived our best in terms of provision, service provision, and we saw these individuals literally, again, another team, isolation was one of the key issues there. When we're talking to adherence to medication, that was very difficult because individuals were not able to go and look for their medications in some instances. Some couldn't afford because, again, many individuals lost their jobs, their way of income. Isolation, again, disallowed. And in a sense of overall stress and overwhelming stress of persons knowing that because of a compromised immune system, they were one of the head individuals, a subpopulace who were most at risk for, contracting COVID or having or seeing the wrath of COVID at its worst. So for us, what we had to do was to strategize and see a way forward in terms of literally ensuring that whatever we do, it would have to be on a one-on-one basis with these individuals, and it would have to take a new approach whereby, of course, besides just the health and well-being of the individuals, the health and well-being of the service providers, ourselves or organizations, was paramount as well.
I love where this conversation is going, but we definitely have to take our third break. But when we come back, we will dive deeper into what were these impacts faced by these vulnerable communities. I'd love to hear the stories if you have any, and yes, we will continue this conversation. So when we come back, we will look into the future. We will look into what the issue was, but also the future of where we can be because of this pandemic, how it has molded us, how it has innovated us. But yes, when we come back, we'll have that and more. You are watching Beyond COVID. Stay with us.
Right now, the vaccine trials do not show where the COVID vaccine makes any pre-existing conditions worse. In fact, persons with preconditions, medical conditions, that mean that if they get the disease, they are more likely to get a severe disease and are at risk of death. Persons who are obese, have chronic lung problems, cardiovascular disease, kidney disease, or any other serious disease, they are protected from developing the complications of severe COVID. So it is better to take the vaccine even if you have medical comorbidities or preconditions.
The owner of the apartment where I lived with my girlfriend would never say why he had asked us to leave, until one day he confessed that he had received complaints from the neighbors about two women living together in a building where there were children. He told us that the neighbors had commented that we could have COVID and that our lifestyle made us more susceptible to catching and spreading the virus. Homophobia and surfacing prejudices during the COVID pandemic can make it difficult for LGBT persons to confront day-to-day life and protect our health and that of others. How can we stay home if we are put out onto the streets for simply living how we live and being who we are?
We've all been impacted by COVID-19, but there's more than one side to the story. These are the stories that go untold.
Persons living with HIV can take the COVID vaccine. In fact, we advise them to take it, especially if you're someone who is taking your antiretroviral medication every day, as you should be. Then it means that your immune system is operating at a good level and you can take the vaccine. Now, even for persons who are not on treatment, as long as they're not seriously ill, with HIV, then it is still advisable for them to take the vaccine, but make sure you take both doses of the vaccine so that you can get good protection from the vaccine against the disease.
Welcome back to Beyond COVID. Here with us, we have representatives from the civil society organizations. We have Kiran Cacho from Go Belize, as well as Dericia Castillo Salazar from Our Circle. We continue our conversation on how COVID-19 affected persons infected with HIV, as well as the LGBT community. You touched briefly on, Dericia, persons that had to leave their life of solace to go back home, that essentially you'd think would also be, but would experience the opposite. Yeah. Not being tolerated, not being accepted, but also carrying the anxiety of COVID-19 being transmissible within the household. Talk to us about vaccination rates. How did these members try to combat the spread of the virus?
I think the persons we engaged initially were hesitant. And I think that was a global initial reaction to this vaccine. There were a lot of naysayers, there were a lot who were pro-vaccination, and it was up to civil society organizations to engage the Ministry of Health to get the truth so that we can give that to our community. And I can't say it was a big rush for our community members to be vaccinated. But one interesting thing I can say is when we were able to identify resources to initiate a campaign to get our community members vaccinated, if I'm not mistaken, this was in August of it was later in 2021 where we were able to identify resources to do this campaign. And a good amount of our community members had either already received their first vaccination shot or were awaiting what would be known to us as boosters. So for us, initially it was very hard to convince the community. But by the time we were able to come together to mobilize and say, okay, we need to start bringing this out to our community members, a lot of them had been vaccinated individually. And for us, that was something that was hopeful, because we do have that intersectionality within our vulnerable populations where we had persons living with HIV. And we knew that at the onset of COVID, these persons were called in by the Ministry of Health and given, I think it was up to 2 months, right. 2 months of their medication so that they would not have to be moving around. And one of the interesting, but also one of the concerning thing for us as civil society organizations was the fact that these mobile clinics were no longer going out to communities, so they were no longer accessible, because we saw where the country took a shift from HIV and started focusing on COVID. Yeah. On COVID. So for us, what we saw was that it was something pretty much a live or lose situation, because we have our community members who are PLHIV, persons living with HIV, who felt as if, though, okay, well, I'm here at my 2 months mark. If I go to the hospital, I'm already vulnerable. And it was a very heavy campaign for persons living with HIV to get vaccinated. So for us, by the time civil society organization was able to pool resources and mobilize into the cricks and corners of our country to find our community members, a lot of them had already been vaccinated, at least had their first vaccine. So there were a few who we still had to go out and educate and convince, to a sense, to get vaccinated.
I think I also want to touch on, before we go over to Kiran, or you can also answer this question, the stigma that would come with persons that are infected with HIV, coupled with HIV and COVID. Could you talk to us about that?
Again, in the early onset of COVID, all of us somewhat were stigmatized, or we did some level of stigma and discrimination based on what the unknown. For us, it was very challenging in the sense that we knew immediately how this would impact persons living with HIV. We, as a country, still struggles with retention rate of providing services, of adhering to services as it relates to HIV. Specifically HIV, the utilization of HIV medication is still a trouble, it's still very challenging in our country. And so in looking at that, and then at the same time looking at, you know, the probability of staying, well, literally staying in a household, many of these individuals don't have the luxury of having a household with 5 bedrooms or areas where they would isolate, etc. They literally, sometimes you'd find a household whereby there's 4 to 5 persons sharing maybe a 10 by 10 feet room, all of these things. And then again, mentioning the fact that the modality, the mode in which COVID-19, you know, is actually transmitted, it was very challenging. And again, it goes back to the psychological issues that that persons living with HIV already have. You're talking about stigma and discrimination, whether that's internal stigma or they do exist stigmas that exist within our community settings. It's really overwhelming, it's burdensome for these individuals. So for us, what the Hub or the Hub Secretariat did was we tried our best to continue to, how would I want to say, work with the Ministry of Health, or to continue to build the relationship that was already there with the Ministry of Health in sort of, you know, bridging the gaps that already existed. Yeah. So in one instance, as was mentioned, the mobile clinics that does not exist, with whatever little resources we had, we would go out and try to, you know, take up that and bring the services to the individuals. We had a very unique relationship with the Cayo district, whereby we worked with social workers and visit and go house to house and provide medications and psychiatric care at the same time, and COVID vaccines at the same time. Those worked well, but I can tell you, based on the experience, based on the storylines, I can tell you that personally these individuals were very much psychologically affected by COVID itself. And again, talking about individuals who still stigmatized because of the lack of information as it pertains to HIV, still feeling that, you know, for whatever reason they're at risk, that persons living with HIV are lesser than, for the lack thereof terms. These things are still, you know, very prevalent in our community. Do
you think that the persons within the persons that were infected with HIV carried a sense of urgency to become vaccinated, or to just protect themselves as much as possible to not be infected with COVID-19?
I think it was a mixture of both. There were some individuals, and I think the government did its part in terms of documenting and making a strategy whereby persons who had some underlying conditions were some of the primary entities who were able to have the vaccinations. And again, like some of us are skeptical in terms of any kind of vaccination and consumptions. So that still exists itself. I think it's a matter of us providing the information, and then at the same time looking at, you know, what would have been the outcome as a community of the effect of these vaccines. It did have some impact, but many of the persons living with HIV that the Civil Society organization or the Hub itself engaged with, some of them took the initiative to go ahead, recognizing how at risk they were as individuals.
I think one interesting thing is the fact that during the height of COVID, I don't think, and I'm speaking on our circle, maybe Kieran has a different input, but I don't think we lost a lot of our persons living with HIV. Okay. I think the era where we're in now is where we're losing them. And I'm not sure if it's because during that time there was a lot of attention being paid to the community that had the underlying issues. Like I said, the country shifted from HIV to COVID, but then that was where civil society stepped in, and there were a lot of mistakes made by Ministry of Health, a lot of mistakes made by civil society organizations. None of us handled it 100%. But I think during that time when COVID was the national priority and civil society saying, okay, we can't only be doing COVID, we have to cater to our clients, because that we engage these people. These are our clients. These aren't numbers. These aren't PLHIV. We know most of them by names. We know their family. We can relate to them on that level. For us, it was, we saw where we had that time, and I'm not sure if it's because, you know, everything shut down, so we could actually cater more extensively to those persons. But we had that time where we could reach out to their needs, where entities such as CVC, such as the Global Fund, they ensured that globally HIV remained a priority, and that was fed to the civil society organizations to be able to, you know, continue these services to these vulnerable populations. And I can, off the top of my head, say that our circle has lost more PLHIV clients now that we're simmering down. And again, a lot of it has led to the internalized stigma, because we've done a lot in regards to the stigma and discrimination of HIV, but it's still very real. A lot of these people had their medication, got their medication, and again moved into homes where no one knew that they were HIV positive, because that was such a personal thing for them. So what they did was, it was a bit of a, and I'm speaking on some of the cases that we had, it was a bit of a priority for them not to get sick, not to go to the hospital, not to have their status revealed. So they took better care of themselves then, because everyone was in this close proximity and would know a lot of information, because someone would have to take them to the hospital.
Yes.
Someone would have to get information on what's happening. So to a sense, we saw where COVID created that sense of accountability and responsibility for persons living with HIV, because they were in such a close space that they wanted HIV to be their issue and not everyone's issue. So that allowed them to remain healthier. But the more we started separating, because the COVID restrictions were lifting, people went back to their normal isolated self and doing what was best for them at that point. So for us, that was a very interesting thing, that we started losing clients late last year into early this year, rather than during the height of COVID.
That's so essentially you're saying that during the COVID pandemic was when people exercised most responsibility, and now that it's dying down, which also takes us to the conversation that we had with Dr. Diaz about COVID fatigue, them just kind of being tired of this responsibility of constantly have to think about, you know, I guess taking care and protecting themselves, that now it's like, let me relax.
Yeah, and we have had new cases of HIV. And I think it was last year, one of our youngest positive was a 17-year-old.
Right.
And for us, that was a very touchy conversation, because here we are, this family who survived COVID, and I use that loosely, and being introduced to what some people still see as a death sentence. So for us, that was something that, again, we had to navigate. How do we do this? How do we support these people, letting them know, you know, it's not the end of the road. Undetectable is a thing. If and again, it goes back, and you use this word, and a lot of people wouldn't appreciate the word, but I think it's a level of responsibility and accountability for your own health.
Yeah.
We're here, we want to see you in the next 10 years, the next 20 years, but it's up to you. Yeah. We can only do so much. We can take you to where the medication is, we can support you to get the nutritional packages, but it's a responsibility that these clients have to take on for their own. And it's Oh, it's a lot.
So what would you say is the strategy that the CSOs have to take on now to ensure that the communities that you guys serve remember what the focus is?
As a part of the civil society organizational hub or the secretariat itself, I think one of the key things that we need to continue to do is to build the capacity of service providers to specifically look at more cultural competent service provision for those affected, persons living with HIV, the LGBT community. I think a lot of investment has been made in previous years since we did garner some funds to look at that through CVC and Global Fund to build the capacity to, do something as basic as understanding, who is an MSM, what does an MSM look like, what's the life of a person living HIV, and try to ensure that, they see their relevance in providing those services, because it does play an integral role or a very important role in patient retention and client retention when it comes to service provision. And I think also looking at not just looking at HIV as a single item, a single health item, but looking at the whole holistic aspect of what it takes for me to change my behavior, whether it be for me to, abstain or just follow proper sexual practices or better health practices. And then also looking at the psychological, the psychological issues that exist, or the environmental issues that exist within our communities, the lack thereof health support, the lack thereof finance, the lack thereof, the key things that would make me a better and a healthier individual. That's what civil society should look at, and all encompassing the rights-based approach, looking at, the rights of an individual and ensuring that the state provides for those individuals regardless of their backgrounds.
There's never enough time to cover conversations like this, especially when tying it into what the entire country has faced in a matter of 2 years, is still facing currently. We are adapting, and we thank you so much for being a part of the conversation, for sharing what these vulnerable communities had to face. And that about sums up our panel discussion that we had today. Thank you so much for joining us on Beyond COVID, a panel discussion organized by the Caribbean Vulnerable Communities Coalition, CVC. I'm your host, Sabrina Daly.